that framework already, you don't need spoon feeding so much. I haven't really got any slides like that this year, kind of got more questions. So the information is going to be a bit less kind of comprehensive. It's going to be little pockets of knowledge. Hopefully it'll fit into what you guys already know, and hopefully it'll highlight the important stuff. And the SBAs are going to be sort of shorter in the vignettes this year as well, because that's how UCL do it, and it's frustrating, but we just think it'll help to prepare you guys for the exam this year. And then a note about the pictures as well, which is a bit of a funny one. UCL and the PSA use what are called Creative Commons images, i.e. ones that they don't have to pay to use. And they basically get them all from Wikipedia or dermnet.org. So I've tried to do the same. The thing about that is all the pictures they show are of white people, which is good in a sense that derm conditions usually are more obvious on white patients. So you can be assured that what you see in the exam will be that. But I would have liked to give kind of comprehensive images of what conditions look like in all races, but it would have meant a load more faff kind of pouring through websites trying to find out which images I couldn't use. So I've just mainly stuck to DermNet really. But yeah, if you guys search conditions and go on Google Images, it shows the free ones first usually. And I've done that after every exam at UCL where they've had pictures, and the images are always on the first page. So if you can go to the effort of looking stuff up and looking at the first like 20-30 pictures, you'll probably see what's coming up in the exam. And with some luck, yeah, some of the pictures that are in here you might see again. I think some of them are familiar, i.e. we've seen before, but I'm not sure. And then the last thing to talk about before we get started is we wanted to clarify that the traffic lights don't mean easy, difficult and average. So don't be chuffed with yourself if you get a red one right, or pissed off with yourself if you get a green one wrong. It kind of relates more to the frequency or danger of a condition. So if it's red, it means it's a rare condition. You probably won't see it in real life, but we've got a question on it because we may or may not have seen it previously. It may or may not be an exam classic. The green ones really are the ones that you're more likely to see. They're more kind of foundation program prep, and the yellow ones are just in between. And then, yeah, if you look at this first column on the left, this is kind of makes up the first half of the lecture. These are what we've got loads of SBAs on. So acne, eczema, psoriasis, cancer, and some derm emergencies. I think you may be guaranteed to get 1 or 2 SBAs on each of those topics in the exam. So maybe 10 or 15 roughly. You might get 1 or 2 on blisters and lichen plainness, and then at the end we can do some spot diagnoses. I haven't got any SBAs for them. I just thought it'd be fun to go through because you might see them and recognize them, or you might see them, find out what they are and be like, oh yeah, I've heard of that. But yeah, we will get started. These are a few things that are on the curriculum map. Oh, Nazifa, the slides, if you go on the Teams, I've already uploaded the file, so you'll be able to get it. If you go on the map, these are topics that are listed, but I haven't seen in an exam, and I wanted to kind of trim it down to really the essentials. So I've missed these out, but they're easy enough to learn yourselves. So Isaac, if you're happy, we'll get started on the first SBA. I won't read it out because I think it's a bit off-putting, but we'll give it a minute. And then Isaac, whenever we get a good number, you can close it and I'll go on you. Isaac, do you want to close it if you're happy? Cool. So there's a few things we want to talk about with eczema, and acne rather. That's that there are 3 sort of severities that you want to recognize, and then there are a few steps in treatment. So you can class it as mild, moderate, or severe, which we'll have a slide on afterwards with some pictures. Mild and moderate have non-inflammatory lesions, which are like the classic acne, so whiteheads, blackheads, pustules and papules, but they don't have cysts and nodules. So you can see the first highlighted bit, this guy's got non-inflammatory lesions. And it says he's got several, so we're thinking this is mild acne. And the first treatment is topical, so we can go for topical tetracycline, topical retinoid, or benzoyl peroxide. The only one I gave was tetracycline, which is why that was correct. A lot of you have put oral tetracycline. This case wasn't quite severe enough, and I feel that I've explained why. Moderate acne is treated with orals, like tetracycline, for example. Severe acne, which is managed not by a GP but by dermatology, would be oral retinoids, like a systemic therapy. And here are the pictures that I mentioned. So you can have a look on the left, non-inflammatory lesions that are sparse, and then a higher density of those same lesions in moderate, and then severe. It's not crystal clear on the picture, but there are nodules, cysts, scars. So those are the buzzwords that you want to look out for in a question if you're not showing a picture. Okay, we've got another SBA if you want to go, Isaac. This is a UCL classic, by the way, which is why I've included it. And this one's either know it or you don't really. You can kind of guess from the species name. But I've made this a bit of a naughty question, and we'll talk about why. So let's see what everyone's put. Everyone's put Propionibacterium acnes, which is good because when we may or may not have had this question in the exam, that may or may not have been the right answer. Cutibacterium acnes is the more updated version. It's the same organism basically. They've renamed it. So Propionibacterium is the one that you learn about, and which I guess has been the name for a longer period of time. I put these two options here just because I wanted to raise the point that if you get asked about this organism, it'll be one of the two if UCL have updated the question, which, let's be honest, they probably haven't. Okay, another question. This one's quite a good one. It's kind of modelled off PassMed because it makes a really good point. I'm going to shut my window as well because my door's banging. Right, Isaac, would you close the poll? And then we'll talk about this one. So we've seen that recognizing acne is straightforward enough, so you won't get that in a question. I think the questions gear more towards the treatment of it, because the treatment is it's a decision that needs to be made between patient and clinician, because you can really tailor it to specific demographics. So the patient I was kind of describing here has PCOS, which means she has elevated androgens, and Dianet, which is a combined pill, has anti-androgenic effects. So in these patients, the combined pill, I think specifically Dianet, is really, really good at controlling their acne, as well as providing contraception. But even in young women who don't have PCOS, this is a good method of control for both kind of contraception and acne. Would we usually get brand names? Probably not, but Dianet is a special case. Sorry, I clicked on there. It's a special case because I think it's particularly good. Maybe Amelia can comment on that. I think we have been asked about it previously, or we've certainly been taught about it. So no, it's not the norm to get brand names, but I thought it was worthwhile including. And then other contraceptive methods, by the way, I don't think they do the same thing. Like, I don't think the Mirena coil, for example, would give you good acne control and contraception. Let's go on to another question. This again is raising quite an important point. And if you know, well, I won't spoil it. You guys can figure it out. All right, cool. Isaac, can you close that? Let's see. Yeah, nice. So most people realize that there's only one drug that was presented that's really safe in pregnancy. So let's go through it. Second one, Dianet. And I'm not sure why, maybe it's to do with like venous thromboembolism, but you don't give contraceptives during pregnancy, which is logical, I guess. Tetracyclines and retinoids, you really need to know that they're teratogenic and you would never ever give in pregnancy. And topical retinoid, I googled this. Maybe in reality you can give it. Who knows what the systemic absorption is of topically applied retinoid, but do you want to be the one to give a known teratogenic drug? Probably not. So benzoyl peroxide's a good choice. And this was moderate. It's a picture maybe of a guy, but whatever, it serves a purpose for the question. We've got another question, Isaac. And then if you want to close that there. Right, so let's see what you've all put. Nice. I'm trying to catch you guys out with this one, and you're all a bit too good for me. So you recognise that this is severe acne, so it's got inflammatory lesions and needs to be treated with an oral retinoid, which is not something that a GP would start. Maybe a bit of a fine point, but it's kind of, you need to be able to recognise when a condition goes from primary care to secondary care, which most of you did. So anyone who put oral isotretinoin, that's the right treatment, but note that we're talking about management and it's not for the GP to manage at this point. So let's move on. We've got another, this one's either know it or you don't. And I've included this because we may or may not have been asked about it previously. That doesn't necessarily mean in the SBA paper. We've done practice, Moodle quizzes, mock papers, what have you, and they're all taking the same bank. So basically, I've included this because at one time or another, I think UCL have tested this. And because it's know it or you don't, we'll close the poll there and move on. Nice, yeah. So this is Rhinophyma, which means swollen nose or swelling of the nose. Basically, see it once, never forget it. It's associated with rosacea, which I've included in this section because it's commonly called Acne Rosacea, which is a misnomer. It's not actually acne, but it looks a lot like it, which I guess is why it's so named. But yeah, Rhinophyma, just typical, like severe rosacea, I guess. And you can get similar swellings of other parts of the face, like the eyelids and what have you. But if you want to look that up yourself, go ahead. I haven't got a question on it. Isaac? Okay, can we close the poll? Nice. Okay, we've got a bit of a split here, which is good. It raises a good talking point. So this is, again, this is a question about rosacea. It's called acne rosacea because it has the same papules and pustules, so you can maybe get a misdiagnosis. Other classical features are flushing and telangiectasia. I've got a picture of telangiectasia later. You can see that this lady's obviously flushed. I tried to describe what I thought was mild to moderate rosacea, the first line treatment for which is metronidazole. So I put those other options because they're acne vulgaris, like the more common acne treatments, just to kind of catch you out. And then topical steroid I included because it's got a bit of a funny kind of effect on rosacea. It makes it better for, I don't know, a couple of days or weeks, and then makes it way worse. So it's worth avoiding in rosacea. And then if we move on, this is a new feature I'm going to have in the lectures. It's like a recap relating to the topics. So the key points to take away regarding acne are it's easy to diagnose, so you won't get any points for that in the exam. It's more about getting the correct treatment. So questions 1 to 3 address that. Consider the patient. Are they male, female, pregnant, non-pregnant? Have they got kind of idiopathic or, yeah, just like idiopathic acne or related to raised androgens? Just remember that bacterium as well. It might get you an easy mark in the exam, fingers crossed. Oral tetracyclines and retinoids are never to be given in pregnancy. The latter, oral retinoids, are started in tertiary care, or secondary care rather, not by the GP. Rosacea causes Rhinophyma, which is the big swollen nose that we saw. And then the first line treatment for rosacea is metronidazole. But note that metronidazole will not make that nose go down, I don't think. There's a really cool video of Dr. Pimple Popper surgically managing one. And then let's get on to the next condition, if you won't mind, Isaac. This one's a bit of a toughie, but I've got it for a reason. Okay, would you close the poll there? Let's see what we've got. We've got a good split again. Okay. This is a tricky one. So a woman brings a 1-year-old son to GP with dry red skin, most obvious at the elbows, i.e. the flexures. So it's eczema. And with this presentation, this kind of patient is probably atopic eczema. So this kid might later on go on to have asthma, eosinophilia, what have you. Emollient gel is a really good option. So eczema is managed with emollients, which are moisturizers, and with steroids. I don't think an emollient gel alone is kind of enough to manage this. And you'd probably go for an emollient cream or balm. I think Chris Duovich in his derm talk makes a really good point of going through the different forms of emollients that you can get. Gel is more kind of appropriate for the head and neck. It's like shower gel you would use on your head, or you'd maybe use shampoo, I don't know. So the choice in my mind is between C and D, the two hydrocortisones. Hydrocortisone's a weak steroid. And I was trying to make the point that, especially in a baby, you would go for the weakest you can and kind of step up from there. So 5% hydrocortisone is reasonable, but I think 1 is a better option just because it's weaker and you don't want to kind of overshoot. It's easier to undershoot and step up than it is to come back from treating too aggressively. And there's a really nice, well, not nice, there's a picture of what it looks like. We'll mention this briefly again. Shout out to Chris Duovich. He's got a sick lecture. A really good mnemonic is help every budding dermatologist. So that's hydrocortisone, Umavate, Betnovate, Dermavate, which are, again, brand names. Sorry, Michaela. But if you guys just learn this table, it'll stand you in good stead. Because I think we've had an SBA where it was like either which of these is a potent or very potent steroid, or they give you a steroid and they're like, how potent is this? So hopefully if you learn this, it might get you a mark. But I think rote learning is for you guys to do in your own time. So I'll leave it here, but we'll move on. I've got another SBA. And then if we can close there, please, Isaac. Let's see what we've got. Okay, nice. A split between irritant and allergic. So you've realised it's contact, maybe because they both say contact in the name and it's a bit of a bait question. It could go either way. In my mind, IV is more of an irritant than an allergen. Maybe someone could correct me, but I don't know it to be an allergen classically. So I've gone for basically trying to bring your guys' attention to what irritant contact dermatitis is. That's touching IV or kind of chemicals that you might find in a lab that make you come out in dermatitis. And we've got a picture of that on the next slide. I actually saw this in theatres yesterday, and I thought it was really cool to include because it relates to this. And so I took a picture and posted it here. This is what dermatitis looks like. Similar to what we saw on that baby's hand. I guess this is irritant. I think this is because these people are washing their hands all day, every day. But yeah, that's what it looks like. We'll move on. Another SBA, Isaac. So this lady hasn't been washing her hands repeatedly. And let's close it there. Let's see what we've got. Yeah, nice. So most of you have caught on to exactly what I'm doing. You probably wouldn't have latex containing gloves, but that was the bait point that I was trying to make. Maybe this lady has put on latex gloves and has had an allergic reaction. So you'd assume that her hands would just come out in red, dry, cracked skin. It could perhaps extend beyond the hands. But I think this is the kind of question you get. So whereas in acne, we didn't have recognizing what the condition was, in eczema, we've got different forms that you might be expected to differentiate between. So that's what we've been doing in the last few questions. And maybe that's a hint for the next question. Isaac. Thank you. Let's see what you'll put. This is a bait exam point. And I think I've seen this question before, if you want to take the hint. Okay, let's stop it there. Everyone knows we're on the dermatitis section, so it's quite straightforward. This is what seborrheic dermatitis looks like. Seborrheic means greasy. I think it's related to sebum, which is the skin's kind of natural grease. You can see there that the picture's not perfect. It's kind of got yellow flakes, which is very typical. So you get seborrheic dermatitis in the very young. So they'll have like cradle cap, which I haven't got a picture of, unfortunately, or in the very old. I think because those two groups of people tend to be kind of immune suppressed. And so seborrheic dermatitis, I think I've got a question on it afterwards, actually, is associated with a certain, no, I haven't. I'll teach you on the next slide. Associated with overgrowth of Malassezia furfur, which is a fungus. So the immune suppressed, i.e. those with HIV, those with, I don't know, organ transplants, what have you, get it. And then for some reason, maybe Amelia can tell us, it has a weird association with neurological and psychiatric conditions. So if you go into a psych ward, you might see an inpatient with this. I have no idea why that is.
I have no idea. I'm not sure either. We do know it's associated, but I can't tell you why. The only thing, and I had to look this up, really good questions, really good explanations. With poison ivy, it does tend to be an allergic contact dermatitis, and I wasn't quite sure. I had to look it up, but yeah, just that's the point.
I'll hold up my hat and say sorry, but I hope everyone appreciates the point that the question was making. All right, so yeah, as I said, seborrheic dermatitis is, I'm not going to say caused entirely by, but I think a part of the disease process is growth of Malassezia furfur, which is a fungus. Someone's got a baby with them. Should we mute? Who's that? You're getting muted, sorry. Yeah, treat with ketoconazole. You all know that's an antifungal, and you can use it as a shampoo and put it all over the head and body, what have you. The other dermatitises were treated mostly with emollients and steroids, which we were talking about. This one's not. This is treated with an antifungal. Let's move on. This one, I haven't got it as an SPA. If someone wants to put in the chat, this is a classic UCL bait thing. Again, you know it or you don't. I just want to bring everyone's attention to it briefly. So if a keen bean wants to put the answer, let's see what we've got. Pemphigoid, yeah, perfect. So this is, yeah, nice. Okay, yeah. Okay, the floodgates are closed. Yeah, this is Pemphigoid. Well done, guys. Also called vesicular dermatitis of the hand. Treated with strong steroids. I'm not sure you need to know the treatment, but I included it just because, you know, it's nice. So well done to the guys who got it. To everyone who didn't know that, just remember this. So someone is typically atopic dermatitis is the one that it's associated with. So that'll be in the patient's background, that or eczema, you know, two names for the same thing. And then they'll have a vesicular outbreak on their hand or foot, and it's Pemphigoid. So I think diagnosing it would be enough. You wouldn't know how to treat it necessarily, even though you do now. We've got another SBA. You guys have generally been managing quite well with my naughty questions, so let's see how you do with this one. Okay, Isaac, if you want to close the poll, we'll see what everyone's put. By the way, if we're not giving you enough time to do the SBA, someone put in the chat and I'll slow down. Most of you have gone referred to pediatric A&E. Yeah, so this is, I think, an uncommon emergency, but an emergency nonetheless that can occur in those with atopic eczema, and that is HSV1 infection causing this nasty outbreak. I don't know why it makes patients so ill, probably just because of the virus itself rather than the dermatological involvement. But yeah, they need to go straight to hospital for, I think, IV antivirals, which is why it's not managed in the community. Can we have a little longer on the VVOX? Yeah, sorry, we'll slow down a bit on the next one. Let's go through the talking points for dermatitis. We talked about the mainstay of treatment, which is emollient, aka moisturizer, and steroids. There are other kind of downstream therapies, but I thought it was a bit niche, to be honest. I don't think you'd get asked to name those. There's different types that we need to recognize. So atopic, which is the typical one. Irritant contact, which doesn't get triggered by IV, remember, that's allergic. We've all learned something today. And seborrheic, or the greasy form, which is associated with Malassezia furfur infection and occurs in the immune suppressed and has a weird association with Parkinson's disease, especially in SBA land. Pemphigoid was that horrible vesicular rash that we saw on the hand that you can get in dermatitis. And eczema herpeticum destroys whoever gets it, so send them to hospital for IV antivirals. Amelia, do you want to add anything before we move on to the next set of
the thing with eczema herpeticum as well is if it's involving anything near the eye, they need ophthalmology to see them, because you can get very significant vision loss, and obviously we look in the mouth as well. Often they need intravenous antivirus because they can get quite unwell with it, septic, and then it can spread. You can get systemic infection, and then we switch them to orals. Often they also have a bacterial infection as well, because if the eczema is so bad that they're having eczema herpeticum, it's often both. But it's one of the few emergencies, and we do take it seriously.
Cool, great input. Let's move on. Another SBA. Oh, sorry, this grammatically doesn't make sense. I should have reread it when I was writing it. We'll say well-demarcated regions of disease. We'll call it that. Regions of disease are visible. We'll give you a bit longer on this one. Okay, let's close it there. See what we've got. Nice. So most people said plaque psoriasis, which is the kind of the classical form. If I'd written plaques in the SBA, which in the vignette, which I was trying to allude to, it would have made it too obvious. So plaques tend to be raised, well demarcated, i.e. they have a clear border, and they'll be red. And there's a nice, or not nice, scaly surface over the top, which is typical. Maybe it's the same again. Isaac, if you don't mind. Maybe it is, maybe it isn't. Isaac's closed it. Nice. Guttate, yeah. I looked it up. Yeah, oh, I've got the screenshot. Guttate, resembling drops or characterized by markings that resemble drops. So you might be told that there are teardrop-shaped lesions all over the body. And this form of psoriasis will follow strep throat. This is just a typical thing to come up. You guys smashed it generally, yeah. So sore throat, and then a week or so later, they come out in teardrop-shaped plaques all over the body. We've got another question. Right, Isaac, let's close it. Let's see what everyone's got. Interesting. So a lot of people have gone for Ramipril. I think that's because Ramipril, more often than not, is the right answer in questions. However, this time, Ramipril gets away with it. So there are certain drugs you need to know that trigger psoriasis, and we've got a list there. Beta blockers, NSAIDs, and lithium. Well, beta blockers and NSAIDs are very commonly used. I was going to say lithium's common. It's not so much, but as you guys are in 5th year and psych is a big topic, you could get that in a question. And then antimalarials I've included just for the sake of completion. I think you're less likely to have an SBA on someone with malaria prophylaxis. So yeah, just learn beta blockers, NSAIDs, lithium trigger outbreaks of psoriasis.
Can I add in that I think ACE inhibitors can also worsen psoriasis? So I would give A and B both the right answer.
Okay. I'm glad we've got an actual expert here rather than a charlatan telling you.
It is rare. The drug will trigger it or worsen it, but it's definitely something worth thinking about.
Okay. Okay, I'll have to upload an apology video afterwards, maybe. But most people said atenolol, so I'm going to tell myself it's fine. We've got another SBA. Right, let's see what everyone's put. Okay, most people have gone for E. So if this were acne, for example, I would advise that we start with topicals first and then move on to orals. Whereas with psoriasis, it's a bit different. In fact, sorry, no, it's not. What I'm saying is you would go for monotherapy, whereas here you start with dual therapy. So vitamin D, Amelia, maybe you can tell us why vitamin D works. I have no idea. We all know about it, you know, its involvement in calcium metabolism and what have you, but it has some relation to the immune system.
So, I mean, you know that psoriasis is due to overproliferation of keratinocytes. They're overactive, and then they cause they produce lots more keratin than they should, and that's why it looks scaly. And you also get inflammation, and that's the redness and the itch. What vitamin D analogs do, and I'm not sure what we know is that sunlight seems to improve people's psoriasis, and then from there they found vitamin D also does. It induces differentiation of keratinocytes, and it also lowers that proliferation, which is so high in psoriasis. I do agree that when they're you can buy vitamin D preparations and obviously steroid preparations. And if patients have two creams, they should separate them, use them in different times of the day. But there's new creams, which are, the pharmaceutical companies have been quite smart, and they've been able to combine both. And actually, they can use one cream that's got both. But yeah, if they're separate creams, then they should be used at different times of day so they don't disrupt each other out.
Okay, cool. I don't think you would get two options in an SBA, one where it says same time of day, one where it says different. I think this was in Chris Duovich's session again, which I'm just echoing. I thought it was an interesting point. Let's move on. This is a good question, by the way. I think I nicked this one from PassMed again, because it's important. Okay. So I wouldn't say that there was one rule that fit all situations. However, NICE do specifically say that if you use a potent steroid for 8 weeks or more, you need a month-long gap between. Otherwise, you risk side effects like thin skin, ecchymosis, and all the others that you guys know. Let's move on. Let's see what we've got. Okay, interesting. A lot of people have gone for A. That's fair, because what I was trying to say earlier that I got mixed up in is you do go from topical to oral. However, this is what Amelia said. UV is really good for psoriasis. So before you go from topicals to orals, psoriasis has UV light in between as the second line management. So you've got.
Can I add in? I think this is a really good question. I think, yes, you're completely right. We go from topicals, Then we go for foot therapy, as long as it's not contraindicated. You would never ever use oral steroids in psoriasis, or you'd be really careful if you do. It does help, but when you stop the steroids, they often get a rebound and they can end up with really, really bad psoriasis, end up hospitalized. So we're really careful about oral steroids. The systemics would be your next option if foot therapy fails. We use methotrexate and cyclosporin, another immunosuppressants, and then biologics would be your next line because they're expensive, if the normal immunosuppressants don't work. It's a good question.
Thanks very much. I actually wrote this one myself. I'm going to give myself a big pat on the back later. Could you tell us what would make you choose between UVB and PUVA?
So depends on where the psoriasis is. For plaque psoriasis, we tend to go for UVB. So PUVA is, so psoralen is a sensitizer, which can be given orally, or sometimes we give it as a cream. So if someone's got, for instance, and we use it for eczema as well, just hand or foot, kind of very localized, hand and foot psoriasis or eczema, we use topical psoralen and UVA, and they just put their hands, kind of like when you go get your nails done, just under a UV light. But there's kind of specific cases, so most of the time we use UVB.
Okay, cool. I think that distinction is beyond the scope of our exams, but that is interesting to know. We have another SBA about the same patient. We've kind of given this one away, so I hope you all get it. It's a bit of a naughty question, actually. Let's see what we've put. Okay, we've got a split between methotrexate and cyclosporin. That's good. We'll do another SBA and then we'll talk about why I put methotrexate. You could argue it either way, but there's something to note, which we'll come back to. So let's do another one. All right, Isaac, will you close it there? We'll see what we've got. Again, it's the same split. So that's good. So we've highlighted an important point here. Let's go back to the first question. The usual go-to when you start in systemic therapy is methotrexate. There are certain instances in which you would want to go for cyclosporin or acitretin over methotrexate. So methotrexate, remember, is used in psoriatic arthritis as well. So psoriasis isn't just a dermatological condition. So it is really good in that sense. It helps the joints and what have you. Whereas cyclosporin, which this guy had, works a lot faster. Not sure why that is in terms of cellular pathways and what have you, but standard, like usual go-to, methotrexate. In certain cases, if you want really fast response, cyclosporin, and we may or may not have had a question on that. And that is that for psoriasis. So let's have a quick recap. Typical one is plaque psoriasis, which you're all pretty good at recognizing. It's raised, red, well-demarcated plaques with overlying scale. And another type, guttate, which remember is teardropped, is triggered specifically by strep throat, or at least in exam land. Psoriasis is triggered by beta blockers, NSAIDs, lithium, antimalarials, brackets, and ACE inhibitors. After topicals, we go for phototherapy before we go on to systemic therapy. 4-week break from potent steroids. I should have actually put that in the dermatitis section. Whatever. And then cyclosporin works fast. We'll move on to another condition. This is a really important one, so I hope you all do well. Let's see what we've got. Okay. So 22% will learn now and hopefully never forget that an ulcerated lesion with pearly raised edges, I didn't want to put pearly because it's too bait in my mind, an overlying telangiectasia always means BCC in exam land. As far as skin cancer goes, BCC is the least threatening because it typically only locally invades and doesn't metastasize, but it's still cancer. So you want a 2-week wait, any suspected lesion. And to be honest, an older patient with a persistent ulcer, better to be safe than sorry, maybe. We've got another SPA. Okay, and if we can close the poll. This is a bit of a niche question. Yeah, there's a split as well. So I think very few people amongst you will ever excise skin cancers. So it's not like super essential knowledge, but I think because we've had a question on it, I included it. You will know, or some of you will know, that melanoma excision margins are dictated by the depth of growth, whereas in BCC, 4 millimeters is just something to learn for exams. And yeah, I haven't had a question yet on specific management of BCC. You remember, let's go back to it. There are several options. So 5-fluorouracil, which I think is a cytotoxic maybe. It's like bazooka, that verruca, but for cancer. There's a different ways to manage it. So you can use topical therapy, you can excise it, you can use Mohs micrographic surgery if it's in a cosmetically important area. So I don't think you'd have to pick the management. I just think you want to recognize it, know the principles of management, know when to refer.
So your gold standard is always going to be excision for basal cells. If they're very small, what we call superficial basal cell, you could use topical therapies like topical 5-FUDIX, fluorouracil. Cryotherapy is not great because you don't get histology, right? You're just burning, freezing it off.
Yeah.
Mohs, once you've got proof that it is a BCC with the biopsy, if it's on a high-risk site, if it's on the face, we go for Mohs micrographic surgery. So that's the time. If it comes up as a question, it'll be that someone's got a biopsy-proven BCC on their nose, on their cheek. What's the best option? Then it's Mohs, because you end up with a smaller hole, basically.
Yeah.
But if you had to choose between lots of options, unless it's very clear that it's very superficial, very mild, it's always surgery. That's your gold standard.
Okay. And the reason why Mohs is used on the face is they will chop a little bit out, look at it under the microscope, and if the margins aren't clear, chop a little bit more and they'll kind of chip away. Whereas if you were to go for classic excision, you would risk cutting out more than you needed to cut out, as Amelia said. We'll move on.
Or risk not taking it all out, and then the histology comes back 2 weeks later. In your deep margin, there's still cancer left, and you have to bring the patient back and do another operation, which you don't want to do on someone's nose. So not every hospital will have access to Mohs. Sometimes they'll just have to do normal surgery. So only specialist places have access to it. But if you do, that's the best.
Okay. We've got another SBA. This is a bit of a toughie if you're not sure what you're looking for. If you do, you'll think this is an easy question. Let's see. I thought I'd catch a lot of you out. So yeah, I've given this a red light because I think it's rare for someone to be a transplant recipient, but it's an important topic in SBA land, apparently. Anyone with an organ transplant who is on immune suppression and who gets a suspicious lesion has SCC until proven otherwise. So well done on getting that right to 90%. The rest of you guys, hopefully you'll remember this next time. Transplant plus suspicious skin growth equals SCC. Okay, so the same guy has biopsy done. And there's, I thought I'd throw in a bit of pathology to make it a more comprehensive, enjoyable session for you guys. And just hopefully to clarify a niche point as well, one that can be a bit confusing. Okay, let's see what we've got. Nice. Yeah, okay. So I didn't know this back when I was at your stage. A lot of, so solid cancers, you can think of them as in situ or invasive. So this guy has an in situ cancer because it grows. So this is derived from keratinocytes, which make the epidermis. This is a cancer that is contained within the epidermis. So it's in situ, and SCC in situ or intraepithelial SCC is known as Bowen's disease. So they could be a bit like harsh in classic UCL style and give you this eponymous description for SCC in situ.
That's a good question as well. We think of it as a spectrum. We know you start with actinic keratoses. If it gets deeper, it's Bowen's, and Bowen's is you remember your layers of the skin is epidermis, and then the basement membrane, and then below that is your dermis. So if you've got SCC looking cells, abnormal keratinocytes up above the basement membrane, they haven't breached it yet to go down into the dermis, we call that Bowen's or SCC in situ. If you leave it long enough, it has got a high risk of becoming a squamous cell carcinoma. It's got a high risk of breaching down and invading the dermis. So it's just, it gives us a level of risk by looking at how deep it is.
Let's think about that spectrum of disease again in another riveting SPA. I think you guys will do well, given that you, on the whole, got Bowen's disease. I think this is another one we've had a question on, so I thought I'd throw it in. And I think I've seen this picture before as well, if you know what I mean. So yeah, nice. Most of you have got it. Amelia can probably explain better. Bowen's is pre-SCC. I think actinic keratosis is almost pre-Bowen's. As you said, they're on the same spectrum. It's basically sun-damaged, maybe, I don't know, I don't want to give the wrong explanation. Amelia, would you please?
Yeah, it's sun-damaged skin, and it's you can see they're hyperkeratotic, so you can see how this, the similarities between these and the other pictures, the Bowen's and the SCCs. You don't need to treat them. But they have a very small risk of becoming Bowen's or SCC. So when we do see them, we like to treat them. And is there a question coming up, or can I tell you about treatment?
Yeah, no, you definitely can. Yeah.
In case it does come up, this is when you would use your creams. So your topical 5-fluorouracil or imiquimod, so chemotherapy creams. Or you can, if there's just one or in that year one, you could just cryo that, just freeze it. But if there's lots of them, like that scalp at the top, you imagine you can't, freeze the guy's whole scalp. You would just use the cream.
Okay, we're going to leave SCC there. This may or may not be melanoma. Let's see what you think. Nice, okay. Most people got this. So we've got a slide after to show what the different types of melanoma are. It's a case, again, I think, of being able to recognize exactly what it is. Aqua Lentiginous, I think, means slow growing of the extremities. So you'll have this on the hand or foot. And I think this is potentially what Bob Marley died of, but I didn't verify that. Like, I didn't look it up before the exam. before this lecture, sorry.
Yeah, he did. Acro just means, yeah, the extremities. I think the question is trying to push you towards melanoma, and out of those, you know, when they're on the extremities, then we call them acromelanomas. You wouldn't call it a benign nevus, I mean, because it looks quite odd. But there's definitely something you'd want to biopsy. But obviously, your history is important here. But the question is pushing you towards knowing that the ones at the extremities are called acromelanomas.
Okay, we've got pictures of the main types. So there are other types of melanoma, but I think not so important for the exam. So on the far left, this is superficial spreading, and this is the one that the ABCDE rules most obviously apply to. So the ABCDE rules I've highlighted because they're useful for GPs and I guess other doctors to differentiate between what is a benign mole and what is cancer. So if it's asymmetrical, like that one is, irregular border, different colours, so you can see it's dark on the right. If it's big and if it's changing over time, they're all red flag signs that warrant 2-week wait referral for investigation of what may or may not be a mole. And then the picture on the guy's, just to the right of that, the guy's cheek, lentigo maligna, lenti again meaning slow growing, so it's one of the less aggressive forms of melanoma. I think typically affects the head and neck. Maybe Amelia's going to come in and tell me that.
So a solar lentigo is it's a benign, it's like what we call a sunspot. You get it from sun exposure, and lots of people have them. They're not, we don't tend to worry about them, but rarely you can get a melanoma arising from a solar lentigo, and that's this kind.
Okay. Acral lentiginous we've covered. Nodular melanoma is the worst type, and this is beyond the scope of this lecture, but they can be pigmented or non-pigmented. I think that makes it quite difficult differentiating that from other types of lesions. But if you get an SPA, it will be a pigmented melanoma. It'll be quite straightforward. Here's another important question, and I think we've had this one as well. Oh, nice. Okay, yeah. So I said that nodular melanoma is the worst type, but there's more to it than just a type of melanoma. So the depth of growth is also important. You'll remember when I was talking about excision margins in BCC earlier, they in melanoma govern the prognosis and the excision margins. So a deep growing melanoma is bad. If you had a really superficial melanoma that grew out to affect a wide area, I don't think that would be as bad as a smaller surface area that was growing deeper. So yeah, it's called Breslow thickness, and it's a really important prognostic factor. And I haven't included a slide on the excision margins for each depth because it's rote learning and you guys can do that in your own time. So the key points for skin cancer, they must get 2-week weighted. BCC has a 4mm excision margin, whereas for melanoma, it depends on the depth. And for SCC, I've never seen that on PassMed, UCL, what have you, so I'm not sure. Transplant patients get SCC. That's just an exam fact to learn. SCC is a spectrum of disease, which you guys did really well at recognizing. Actinic keratosis is solar keratosis, which is like sun damaged proliferation of the skin and can lead to SCC. There's 4 types of melanoma to recognize, and they depend on the shape, appearance, part of the body, rate of growth. And then in someone who has melanoma, Breslow thickness, i.e. depth of growth, is the most important prognostic factor.
Can I just add in? I mean, margins is very specialist, but if it comes in your MCQs, so 4 millimeter for a BCC, because you want to make sure it's completely removed. For a pigmented lesion, we tend to remove them with a 2 millimeter margin, even if, if it's an odd mole. The reason is because you need to, if it is a melanoma, you're always going to go back and do another operation. And that second operation, the margins will be dependent on your Breslow thickness. But so what you do is you remove with the 2 millimeter margin. If it comes back as a normal mole, okay, fine, it's removed. If it's abnormal, then they come back and then you do your re-excision with the big margin, depending on your Breslow. Does that make sense?
Yeah.
Because initially you don't know what it is. So initially you remove it with the tight margin with 2 millimeters. SECs are different, 4 to 6 millimeters, depending on how worried you are. So that's a kind of, I guess, rule of thumb. BCC 4, SCC 4 to 6, pigmented lesion 2 millimeters initially, then by Breslow.
Okay. I hate having to just memorize numbers like this, but important. So I've included a bit of it. And we'll move on to another topic with an exciting SPA. By the way, I have got the answer to this question in the kind of section below the slide where you can write notes. I hope you guys can't see it because I can. And if you can, then it completely ruins the question. But for those of you who can't, I hope you'll find this an interesting learning point. Okay, let's close the poll, see what we've got. There's a hearty split, which is good. So it's an important learning point. We've got a few more numbers to learn, actually. So you see that this girl has, you might call it desquamation, I'm not really sure, but blisters over most of the body. Affecting most of the body means it's over 50%. And Stevens-Johnson and toxic epidermal necrolysis are two diseases on the same spectrum. The total body surface area that's affected is important in diagnosing one or the other. So classically, Stevens-Johnson is 10% or less. This patient was 50 or more, so toxic epidermal necrolysis. And you might also have mentioned that it affects the mouth. So this girl had a sore mouth, which is a vague way to say mucosal involvement. I've put that she had sore throat and fever. Interestingly, that can be the first presentation of this disease. So you might have a week of feeling really coryzal, kind of under the weather, and then in the second week of the disease, you can have these blisters come out all over the place. Positive Nikolsky sign, that is when you apply, I don't know what a normal amount of pressure is, but gentle pressure to the skin with a finger, and you can literally just pull the skin away. It means that it's all just falling apart, and it's a pretty bad sign. And I think I've highlighted amoxicillin because that can trigger Stevens-Johnson and toxic epidermal necrolysis, and so can some other drugs. So if you guys want to memorize those, I didn't want to include them, but worth knowing. I've got another question. I think we asked you about this last year. I think Ollie did it, and I think I did it in our respective lectures. But I wanted to include it again because it's important. And again, I think you still have asked us about this. Let's close the poll. So I've given this green light, not because it's easy, but because it's really important to be able to recognize this. I should have highlighted some bits, sorry. So this looks like cellulitis, but the guy is just in a lot of trouble. So basically his sickness is sort of out of proportion with what is visible on the body. Those of you who are really kind of picking apart the vignette, we'll note that he's got athlete's foot. So necrotizing fasciitis, I think, can originate from even tiny breaks in the skin. So if he's got athlete's foot, he might have sort of cracks between the toes and what have you. And with some bad luck thrown in, a skin break can lead to necrotizing fasciitis. And so, yeah, the best thing is to take this guy to theatre and then have a look inside and see kind of how far up the limb it's affected. Because basically you can have redness over the surface that only goes so far. And then once you look inside, the infection of the fascia can go way higher. So yeah, we talked about this in Basque last year. They might have to go to surgery repeatedly, and you're kind of chasing after the infection until eventually you maybe just cut the whole leg off. So not so much a derm topic, but because it's a presentation of the skin, I thought I'd include it. And this question's a bit of a toughie. Either you know it or you don't. But we've had a question on it, so I'll put it in. Okay. Some of you might be kind of wagging your fingers at home saying, actually, this is a surgical question, not a derm question. But because the skin's been damaged, I thought I'd include it. So this guy's had this lady, sorry, has had a really bad burn affecting a significant part of the body. And what can happen when you do that is, for some reason, you get erosion of the gastric mucosa, and so they can present with hematemesis shortly after. I don't know how common this is in real life, but because we've had a question on it, I've included it. Peptic ulcer disease, no one put that, but if you had, I would have let you kind of get off lightly, because Curling's ulcer is a peptic ulcer and it is a disease, but Curling's ulcer is the better answer. Inhalational burn, we've got a question on that afterwards. That would be damage of the airway, whereas brisk hematemesis maybe suggests damage of the gastrointestinal tract as well, instead. This one, that lowercase e on the first option is doing my head in. I didn't notice that. This isn't a super important point in the sense that I don't think you get this SBA, but I just included it for the sake of interest. Okay, we've got a bit of a split. I've written the wrong headline here because I think even I got mixed up writing it, but the nerve endings in the skin that give you pain sensation, they only go so high. So if you have a burn that affects the deep dermis, they're destroyed and it's painless. So a painless burn is a bad sign. Therefore, a painful burn is a good sign. So superficial partial burn is the most painful. Is that important to know? I don't know, but I thought it was interesting, so I've included it because it relates to the anatomy of the skin. This one is more important and arguably a surgical question rather than medical, so I'm sorry, but it's a good topic. I should have told you to bring a calculator, actually, sorry. Let's see what we've got. Okay, we'll close it there. What have we got? Okay, so the Parkland formula is what you use to work out the amount of fluids that someone should receive in the first 24 hours following a burn. And it is worth memorizing because I think you'll have a question potentially in 5th year or final year. And the formula is quite straightforward. It's 4 times percentage total body surface area that was burnt. So this is 30. times the body mass, which is in kilos, i.e. 70. So 4 times 30 times 70 is 8.4 litres, which is what the patient should receive in the first 24 hours of management after the burn. The first half of that is given in the first 8 hours, i.e. the first third of that time, and then the second half of the fluids is given in the next 16 hours. So there was another thing to do in this question, was divide the total volume that you worked out by 2, because it's in the first 8 hours, and give 4.2 litres. That green light does not mean it's an easy question. It's a dangerous condition, having a severe burn, so I gave it green, but I think it's actually quite a tough question. So if you got it right, well done. If you didn't, don't worry. Just learn the formula and learn that the first half is given in the first 8 hours, and that's kind of all there is to this question. We've got another one. Those of you who put inhalational burn earlier might like this question. And this really is a UCL question. I need to stop saying that because I might get myself in trouble, but whatever. Okay, let's close it there. We haven't got too many SBAs left, which is good because we're getting to 7 p.m. and I'm sure everyone wants to move on. Let's blast through this. So most of you have gone for D or E, so you've recognised that it needs emergency management. We've had a question on this. Basically, if someone has inhalational burns, which I gave to you, but you could read in the question because this person had soot visible at the back of their mouth, which is what our SBA patient had. There's risk of I don't know if it's edema or contracture of the airway. I think some of you will know what burns contractures look like. The skin kind of all pulls together. This person, even if the airway is kind of all right now, needs intubating sooner rather than later before the proverbial S hits the fan. Because yeah, they will get worse from here. So intubation early in inhalational burns is an important thing to know. Let's have a recap about emergencies, and then we'll have a note about erythroderma actually, because I didn't put a question on it, but maybe Amelia can tell us about it. So toxic epidermal necrolysis and Stevens-Johnson syndrome are two ends of the spectrum of one disease, i.e. kind of widespread blisters triggered by certain medications, maybe by certain organisms. The cutoffs that you want to know are 10% or less of the total body surface area affected is Stevens-Johnson, and 30% or more, or mucous membrane involvement is TEN. What lies in no man's land in between, I'm not really sure. Maybe Amelia can tell us.
It's not a very clear-cut distinction, but yeah, 10 to 30%. You know, if you're being strict, Stevens-Johnson's above 30 TN.
Okay.
Often it can be caused by drugs. You mentioned penicillin, there's other ones, but it can be caused, so the other one to know is mycoplasma infection, which is more a common cause in children. So just add that to your mental notes.
I think lamotrigine is a PassMed or QuesMed favorite as well. Funny you should mention
allopurinol, cotrimoxazole, other ones, and antiepileptics.
Mycoplasma may or may not be coming up later. Spoilers. Next learning point, cellulitis, where the person's basically just too unwell for it to be cellulitis. Think neck fash instead. Someone who vomits blood after a big burn has a Curling's ulcer. You just need to be able to recognise that, not know how to treat it. Deep burns hurt less because nerves are killed off. The Parkland formula is what you use to work out how much fluid to give someone in the first 24 hours following a burn. And then inhalational burns warrant early intubation. Okay. Now on to blistering disease.
Ed, could we have a little break? There's been a request in the...
Yeah, of course we can. I will put... What?
Ed, I will go after the break. Sorry, guys. Are there any burning questions for me? And then Ed can email me if there's anything that comes up afterwards. I'm very happy to answer them. Unfortunately, I can't stay until the end, but I'm happy to take any questions now if there are.
Yeah, there are a few because I've been running the polls as well as trying to answer the questions. Has been quite difficult.
Sorry.
A few that sort of raised concerns that have come up was regarding BCC management. So you said it was a 2-week wait referral. However, a lot of people seem to think it's a routine referral, and I had a quick look, and it does say routine referral. Just wanted to clarify that.
Okay, fair enough.
It is variable. We do see a lot of query BCC in the 2-week wait pathway, and the forms that the GPs fill out, they can refer query melanoma, SCC, or BCC. I guess it depends on the size and how worried you are. If it's a very small, tiny papule, they might refer as routine, because we do know it's a very slow-growing tumor, but it is acceptable to send it 2-week wait, especially when it's, it's become larger, or you take the whole patient into account. So I think it's acceptable to send it as an urgent referral.
Okay. So NICE guidance says routine referral.
But if it's on the face, if it's large, then that needs to be seen quickly, because and it would be fine. So I think there's special cases, but I don't know how UCL would interpret it, whether they go by NICE guidelines or whether.
Yeah, it tends to avoid topics like this. Well, yeah, sorry for the shitty question. What was
if this was on the face, then it should be seen urgently.
Okay. Another one was, so ACE inhibitors will worsen psoriasis. Will ARBs do the same?
Oh, nice.
You guys are getting very specific. So on my list, my cheat sheet, I have ACE inhibitors there. I don't have ARBs, but they are similar. I don't think that will come up because it's not clear.
With regards to the 4-week breaks with potent steroids, someone wrote, is it 8 weeks break for flexural psoriasis, or should we just assume 4 weeks?
So I would be careful about learning numbers like that. That is not a rule we use in dermatology.
Okay.
If somebody is using, so 8 weeks is quite a lot of steroid to use. And we'd be thinking about, so this is psoriasis patient, yeah. So we'd be thinking about about a steroid-sparing agent, so whether they need a different topical, whether they need phototherapy, whether they need systemics. But I don't know what questions come up in the past, but we don't have rules like that in dermatology. What do you think, Ed? Or you guys have done exams.
I mean, you're the expert, so expertise trumps the likes of PassMed and what have you. I think this is just a common topic that I've seen in questions. So
I'll leave that to you, because it's not a rule we use in clinical practice in the specialist area.
Another one was, at which point does actinic keratosis become Bowen's, and is there a way to differentiate them just from looking at it?
So it's got, again, a very small risk of becoming Bowen's or becoming SCC. You look at the patient as a whole. If it's, so actinic keratoses, they're rough red patches. If sometimes we're not sure even when we see them in clinic, so what we do is we send them for a biopsy. So we take like the worst bits, we take some biopsies. If it comes back as actinic keratosis, then you can treat it, with topical treatment, so 5-fluorouracil or imiquimod. If it comes back as something else, like an SCC, then you would obviously send it for surgical removal. So it's not always clear, but they tend to, so actinic keratoses tend to be flatter, and you saw the pictures of Bowen's and SCCs, which look like a very kind of, like an obvious lesion, which is eroding, it's more hyperkeratotic. So you have to go by the question and go by the patient in front of you. When we're not sure, we biopsy.
Okay. Sorry, I'm just writing a response. Is cyclosporin used because of nail involvement in psoriasis, or because it's quick acting?
Yeah, so the nice thing with psoriasis is we've got a lot of treatment options, a lot of different tablets, immunosuppressants, and then a lot of different biologics, which is, I think, beyond the scope of today. So you have to look at the first patient in front of you and decide, methotrexate is most commonly used because it's got a relatively good side effect profile. It is very slow acting. We tell them, it'll take 2 months before you notice some effect. Before that, we don't, and then it might take up to 6 months for it to have its full effect. So it's a very slow acting one. Cyclosporin acts much faster. It's a stronger immunosuppressant, but because of that, it's got, you could say, more side effects. It's more immunosuppressive, so high risk of infection. And then if you remember, I don't know if you've done renal talks yet, it can be, damaging to the kidney, can cause hypertension. And also with cyclosporin, we only use it for a short period of time. If they're on it for longer than 3 to 6 months, it's got a high risk of having side effects like kidney damage, like hypertension. So it's used in specific cases when you need a quick response, youngerish patients. So here you've got a 50-year-old who need, daughter's getting married in 2 weeks, so they're pushing you towards cyclosporin because they're saying, we want something with a quick response that's going to act, it's going to be effective and act quickly. And that's why you choose that from those.
Okie doke. Actinic Keratosis, is it a 2-week wait solved at the GP?
So it depends. If the GP is worried that there could be an SCC, then it is a 2-week wait. Otherwise, if they can manage actinic keratosis in the community, but they've got access to 2-week waits. So we do see a lot of actinic keratosis because they want us to make sure it's on SCC. Cool. So no, but if you're thinking that you need to rule out an SCC, then it is.
Cool. Okay, and then difference between keratosis pilaris and however you say Pemphigoid. I don't know.
That's niche.
I think that's very specific. I'll need to get back to you on that.
Yeah, I know. What should we? Have we got any more?
I think the one about cyclosporin psoriasis in short term, either carried on long term, will answer no because of the side effects, right? Yeah.
Sorry.
If someone started on cyclosporin for psoriasis short term, then they're not carrying that on long term, are they?
No. You'd use cyclosporin to get you through, kind of to give you a quick effect, get control of things, and then you'd be thinking in your head, what's going to be my long-term option?
Cool. Fine.
That could be methotrexate, that could be a biologic. It depends on the patient.
Okay. Is psychological, all right, last one, and then we'll crack on. I think this is a bit out of our scope as well. Is psychological distress alone an indication for Roaccutane in acne?
So there's it's easy to find the criteria for Roaccutane, nodular cystic, scarring, acne. So it's quite clear cut. If someone's got very mild acne and they've got a lot of psychological distress, I'd look into addressing the psychological distress side of things. If they've got mild acne, you should be able to to control it with topical treatments, with oral antibiotics. Again, you saw that there are many options. So it needs to be because Roaccutane can have side effects, has its risks as well. So it needs to, you need to be treating significant acne. If it's very mild, the treatment is not going to fix the problem, right? Because there might be something else causing distress. So you'd look into that. Sure.
All right. Thank you very much.
Right, you're very welcome. Ed, feel free to email me. These are really good questions, and also a really good teaching session. So well done.
Yeah, cheers. It's been a pleasure to have you. And the guys they've given you good feedback as well. I can see in the Q&A.
Yeah, if anything else comes up, just email me after. Sorry, I can't stay for the whole presentation.
No, thanks again. We haven't got many SPAs left anyway, so.
Okay.
Right, let's go on to the next SPA. Hopefully Isaac will be able to bat off all the tough questions in the Q&A. This is another classic UCL one. Interesting split. I haven't got a slide comparing the histological samples from Pemphigoid and Pemphigus. But if in doubt, go for Pemphigoid, because Pemphigus is rare, whereas in comparison, Pemphigus is relatively common. But the key thing that you can see in this picture is that there is IgG attacking the basement membrane. I've got a slide comparing the two afterwards. Pemphigus, you basically have all the epidermis lighting up green because the desmosomes would be getting attacked. This is hemidesmosomes, which anchor the keratinocytes to the basement membrane, I think, being attacked. Let's move on to another question, and then we'll have the comparison slide to clarify that. Okay. Yeah, so oral steroids are the mainstay of treatment for bullous pemphigoid. Not really anything more to say than that. So this is the comparison slide. As I said, pemphigoid, even though pemphigoid sounds like it's named as a condition that looks like but isn't the same as pemphigus, so it was maybe named later in time, it is commoner. And because the IgG that's involved is attacking deeper structures at the basement membrane, there tends to be like a thicker layer of skin overlying the blisters, so they're more tense, whereas the ones in pemphigus are described as flaccid. You can see in the picture of that guy that there are no intact blisters there because I guess they don't, stay in shape for too long. An interesting point to mention is that pemphigus does involve the mouth commonly, whereas pemphigoid does not. So I said, if you're unsure, go for pemphigoid, but a couple of caveats there that might sway you in the other direction: flaccid blisters and involvement of the mouth. And just a couple of key points of blisters, which I think we've basically gone through. And then we've got one more little section of SBAs before we're going to put them to the side and do some spot diagnoses, just for fun, really. So if we can have an SBA, yeah, cheers, Isaac. Let's see what you all think of this. It's kind of obvious that it's not psoriasis or dermatitis because we've finished with those sections, but I was struggling to think of other options to put in this answer, in this question rather. Okay, let's see what people put. So the P's of lichen planus is another thing to learn. Purple, papular plaques that are pruritic. This kind of, it looks like plaque psoriasis, but you will have mention of papules, I think, that are purple, whereas psoriasis was more plaques in the absence of papules and was described as red. It's a bit tough to tell between the two because this has overlying scale as well, which we call Wickham striae. But with practice, kind of you come to differentiate between the two. Just look out for the P's. Here's another question.
Sorry, I accidentally.
It's all right. No, it's all right. I mentioned Wickham striae as being the overlying silver scale that you can see there. What this question was getting at was that you can have Wickham striae in the mouth as well, i.e. mucous membrane involvement. So I'll go back. The white scale there in the mouth is kind of the same as the white scale there over that plaque. Wickham striae, just a eponymous little sign to learn. How do you treat lichen planus? Isaac? Let's see what they think. This is the last SBA we've got, and then I'll just show you a load of pictures, and we'll see who can write the answer the fastest in the chat. Yeah, topical steroids. Don't know what the disease process of lichen planus is, but it's managed with steroids. Have I just closed? No, okay. I accidentally swiped back on my computer. Let me catch up, and then, yeah, as I said, that's the last SBA of the session. I don't know how you guys are feeling, whether you're tired or not, but after I'd written this many, I was exhausted, even though I've ripped off past mid in a few of them. But yeah, let's talk about the learning points of lichen planus. You recognize it by looking out for the P's: purple, polygonal, papules, and plaques that are pruritic, which I should have put in. Wickham striae is the name of that white or silvery scale that you get over the top. You treat with topical steroids. And we will leave the SBAs there. As I said, let's make this a bit of a race. So I'm going to show you some pictures, and I want you to give me the diagnosis, if you can. Some of them are easy, some of them are hard. We've got 4th year topics, 5th year topics. I just thought this section might be a bit of fun. So if you keyboard warriors are ready in the chat, let's do the first one. I've got a delay. Cellulitis. Yeah, read the question. Read the question, guys. Flu clocks. I'll give it to Claudia. Yeah, cellulitis, antibiotics. Nice. That was straightforward. Could be necrotizing fasciitis, as we've discussed, but go for cellulitis. This one's a really tough one. I've included this because I got destroyed by a consultant on it. Yeah, scurvy. Nice. So we've got perifollicular hemorrhages, corkscrew hairs, and this person would bruise easily. They'd have poor wound healing. I'm impressed with how fast you got that. Here's another 4th year one. Who can get this? It's quite a long name to type out. This idiot. Necrobiosis lipoidica. Yeah, Alid takes it. Necrobiosis lipoidica diabeticorum. So it's a waxy yellow plaque on the shins with overlying telangiectasia in someone with a history of diabetes. These, I don't think you'll get asked about these, by the way. I've just included them for fun. This person has a neck swelling. What do we think? Myxedema. Yeah, nice. This is pretibial myxedema. Non-pitting. The skin gets dark, tight, and looks like an orange peel. You guys hopefully will know this one. I'm not going to give you any clues. I've got a delay in the comments coming up. SLE. Yeah, so this is a Mela Rash or butterfly rash. Note the nasolabial sparing. Rosacea. So yeah, so she's flushed and she's got some telangiectasia. You guys will maybe put in the feedback that I don't know what I'm talking about, but you would maybe expect papules and pustules, which I can't see. Let me zoom in. No, I don't know. I think that looks like Mela Rash. You can put some angry feedback in. And if you do follow that link down there, they've got some well good pictures of basically all the 4th year kind of room topics that you learn about. Speaking of which, who knows what this is? Libido Reticularis. Yeah, exactly. So described as mesh-like or net-like or mottled. Behçet's. Can you get Libido Reticularis in Behçet's? Maybe. Isaac, you can comment on that. If you're here.
I don't think so. It's more like antiphospholipid syndrome. Yeah, I don't think it classically presents in Behçet's.
Okay. From one mottled rash to another. Who knows what this is? Erythema ab acne. Yeah, nice. Redness from the fire. If you put a hot water bottle on long enough, you come out in this rash. This is fun. We should do this every session. What's this? Maybe it's a Mela Rash again. Maybe it's rosacea. No, yeah, nice. Lupus pernio, seen in sarcoidosis. Very nice, guys. Very nice. Ignore the headline for the time being. What are these two? Spider nevus, yeah, on the left. Telangiectasia on the right. Yeah, exactly. So if you were to press down on the one on the left, on the spider nevus, what would be the typical filling pattern? Fills from the middle. Exactly. Yeah, nice. And you might get that in an abdo exam in someone with chronic liver disease. It doesn't help that it's called spider telangiectasis, because it's like, is it telangiectasia? Is it not? But you guys got it. There's a few erythema M. Oh, nice. Spider bills from the middle. There you go. That is a great little aid memoir. So we've got 3 erythema M ... here. Multiforme. I need you to tell me which one. Marginatum. Far right is erythema multiforme. Maybe. Marginatum in the middle. Interesting. Lyme disease is last. We've got some good shouts here. Migricans. So multiforme on the left, and they're your little bullseyes, caused by mycoplasma and herpes. In the middle, erythema marginatum, which you see in rheumatic fever. And on the right is erythema migrans, which is another bullseye, but that'll grow over time, and that is caused by Lyme disease. Nice. Okay, onto a few 5th year ones. I've got one picture from each of the key specialties, and then we'll stop. Eruption of pregnancy thingy. Yeah, it's that polymorphic eruption of pregnancy. And the clue, can you tell she's pregnant? I don't think so, but the linea nigra appears in pregnancy. Yeah, polymorphic eruption of pregnancy. So from a pregnant patient to a young patient, what is this pediatric presentation we've got? Bit of a tough one. So in fact, we'll go back. Yeah, it is impetigo. Pemphigus gestationis, you would have, it would be less of a homogeneous mass, and it would be discrete kind of ulcers left from blisters that had burst or blisters intact. So good shout, but yeah, impetigo. So this is a Staph aureus infection that you see in kids. The next patient is, the next picture, I should have told you that there'd be some disease to genitals coming up, but what's this? Lichen sclerosis. Yeah, nice. And I've got lichen sclerosis of the penis on the next slide. Can anyone tell us what that's called? Zunes. I think it is Zunes, yeah. Also known as that. You can, yeah, BXO, nice. So lichen sclerosis is like, I don't really know how it works, but in a woman, I think you get labial fusion. In a guy, you get meatal fusion, and you can get white patches of skin. And I think you treat that with topical steroids. Okay, we've got an opthal one here. Blepharophyma. Maybe, I've never heard of. Oh, blepharophyma is in the rosacea manifestation. Good shout, actually. But blepharitis, yeah, just inflammation or infection of the eyelid. So you can see the whole eyelid from left to right is swollen and red. This next picture, before we see it, is, you would not ever get the diagnosis in the picture alone, but I've given a classic John Cartledge headline. I want you to tell me more than just what the organism is that's causing it. I want you to tell me the name of the event, if you know it. Preorbital cellulitis. If you come to the opthal session that I'm going to do, we'll talk about that. But that would span beyond the eyelid. Seroconversion, yeah. So this guy is like 4 weeks into having HIV and has a generalized maculopapular rash. last question. What's this? Plagies. Yeah, exactly. So it starts at the nipple and spreads out. Nice. Yeah, you guys are killing it. Guys can also get it. And that's what that looks like. I'm afraid that's the last slide. I think you guys have had fun with the last section. But yeah, that's all. I've got the Q&A up actually. We'll try our best to answer them. Otherwise, thanks for coming. I think Isaac's got a link to the feedback form.
Yeah, I'll just send it into the Teams chat now.
This was amazing. I hate Derm, but somehow made it interesting. That is very
yeah, I must say, I've actually learned quite a lot watching this. This has probably been the best Derm thing I've ever seen. I genuinely think if you just use this, you are more than covered for dermatology in our exams.
But pay attention to the questions that I got wrong, like Ramipril and the 4-week break and what have you. And Chris Duovich's lecture, if you go on Moodle Dermatology, it says Intro to Derm. They've also got a YouTube channel. That is sick. That's really good. Please do the feedback. Or if you're like me, don't do it. Just go and enjoy your Friday instead and leave us wondering.
Not that I like to big Ed up as much as I can, but I think this has been the best SPLICE lecture so far. Very useful. I generally think this will be your derm revision done.
Does anyone have a link to the Chris Duovich lecture? Yeah, I actually do. Let's go to my shout out to it. So he goes through loads of spot diagnoses again and talks about the principles of treatment. I have a link earlier on. Let me see if I can find it. I'm not sure how far back it is. But yeah, if you go Moodle Dermatology, it's Intro to Derm. Let me see. Where is this? Maybe put it in the eczema section. I'm not sure. I'll go Moodle and I'll get you the link from there. It's like an hour long and he talks about more than we've talked about. He goes through loads of benign lesions, which I didn't want to go through because I don't think we had any questions on them. Let me see. Dermatology. Yeah, here it is. Let me get the link for you and I'll put it in the chat. I'm going to have to put it in the Teams chat because I haven't got access to the VVox chat on my computer. Let's see. So yeah, this 4-week thing, I did have a screenshot from NICE guidance explicitly saying that you do. Amelia says otherwise. It's one of those things where, you know, it's a rule of thumb in real life. Do you stick to it? Don't you stick to it? Who knows? But like the point to highlight was that you need a break from steroids. You can't just take them indefinitely. And I will stop the recording there.